Good afternoon, everyone. I am hoping that this is working and that y'all are seeing me. I'm David Kimberlin. I have the opportunity to discuss over these next 10 or 15 minutes a study that is underway now. It's very much a collaborative effort, a group effort of many of the people you've already heard from through the course of this afternoon. It's under the umbrella of the National Institutes of Health, and it's a natural history study of AFM that is going to try to establish a biorepository, data repository, and image repository that will allow us to understand more about AFM as we learn more about what to study, how to use these important specimens. Now, this is a partnership. This is a partnership from organizations and institutions and individuals. The Centers for Disease Control and Prevention, the AFM work group led by Carlos Pardo and many other people that you've been hearing from today, the NIH, as I mentioned, specifically NIAID and DMID within NIAID. And finally, an organization called the Collaborative Antiviral Study Group. And I'm going to spend just a moment to talk about each of these and the work that they've done that brings them to this point of being able to collaborate on this important endeavor. The CDC, as you all have been hearing, established an AFM task force. This is a nationwide group of scientists, of physicians, of public health experts in a variety of different disciplines as well as institutions. And what they do is review and update clinical guidance on the management of AFM, and also through this effort to try to work on better understanding of the causes of AFM. The AFM work group led by Carlos Pardo and as I say, many other people that are part of what you've been hearing here today is a multidisciplinary group as well. It was established to build consensus for the diagnosis and management of AFM, both in the acute phase as well as the longer term outcome phase. And it's set to conceive and develop and conduct clinical research, things that Leslie mentioned to you just a few minutes ago on misdiagnosis. That is being able to be done because of this group, this consortium of institutions and individuals that are working with the collaborative effort to try to move that part of it forward and to facilitate clinical and basic science research in the process. NIH has had a long-standing interest in enteroviral disease in particular, and then, of course, as more became known and the link with enterovirus D68 became better established, also acute flaccid myelitis, David Morins and Greg Folkers, and, of course, Tony Fauci, who we all know very well these days, published a number of about a year ago, actually a little bit more than a year ago, a statement about AFM and what we know about enteroviruses and what mostly we still have yet to learn. And so that's a big part of the impetus that then led to the funding opportunities that are working with this particular study. And finally, the Collaborative Antiviral Study Group. This is an international network of academic institutions established back in the 1970s, funded by NIH continuously since that time, looking at therapeutic and natural history studies of rare viral infections, predominantly congenital and perinatal infections, but also with experience in enteroviral sepsis in populations as well. And this particular group has a multifaceted capacity to be able to coordinate the activities of multiple centers across the nation and indeed across the world. This is a map of the sites that are participating in the AFM study, the NIAID AFM study. And I want to point out, if my pointer will show, that it includes 35 centers across the continental United States, and then also a site at Sick Kids in Toronto, Canada, as well as sites in Peru and the United Kingdom. So again, an international effort here as well. The study objectives, the overall objective is to establish that biorepository, data repository, and image repository that I mentioned before. And this will have clinical and outcome data as well as specimens that are prospectively collected. And they're available with a governance structure and a way to petition for this, for scientists to be able to make the case that they have an idea that needs to be explored about pathogenesis, for instance, of acute flaccid myelitis, or biomarkers of acute flaccid myelitis, or a number of other things as well. And if they can get access to some of those specimens as well as the outcomes of patients that are enrolled in these studies, it could seriously and significantly advance the field. Now, there also are primary and secondary outcomes, things that will be publishable at the end of the study, not only just simply waiting for other ideas to come in and utilize the biorepository. The primary objective is to characterize the epidemiology as well as the natural history of AFM over the first 12 months of time, not so much the out months or the out years, I should say, but over that first year of time. And then secondary objectives are to describe diagnostic evaluations as well as therapeutic evaluations that are being utilized at study sites. So in other words, the study itself, this natural history study itself, is not indicating what should be done in terms of diagnostics or in terms of therapeutics, but as sites are using that, those data will be captured, swept up into the database to identify risk factors for development of AFM as well as determinants of outcomes of AFM. And finally, to look at household members. That's a comparator group that we're able to build in here to describe clinical characteristics of those household contacts of patients who are being evaluated or have been diagnosed with acute flaccid myelitis. There are two study populations. Group number one are those who have acute flaccid myelitis cases. They're suspected of having it or they've been proven to have it. And then group number two are the household contacts of those AFM cases. Inclusion criteria for group number one, those that are suspected of having AFM. Of course, having assigned informed consent. They need to have onset of flaccid limb weakness involving one or more extremities, suggestive of possible, probable, or confirmed AFM within the previous 30 days. They need to have imaging findings of the spinal cord that either have already been obtained or are clinically planned to be obtained. They need to be children under 18 years of age. And there is a minimum weight here. That minimum weight is only because of the amount of blood out to make sure that we don't exceed what is allowed by the NIH or by IRBs for the amount of blood that can go for a research purpose. And unlike some studies where there's an option to select future use of specimens, because the overall objective here is to build a biorepository, they have to agree to future use of specimens from the outset. Exclusion criteria are known conditions other than AFM causing the limb weakness that they have, or if the investigator simply thinks that it's not in that subject's best interest, then of course they would not enroll on the study. Inclusion exclusion criteria for group two, these are the household contacts, of course, signed informed consent. Assent, I should have said for the group ones as well, for the older children as indicated. They need to reside, the group two subjects need to reside in households where a child has enrolled in group one within the previous 30 days. There is that minimum weight that I mentioned before, again, only because of the blood out issues, and they need to agree to future use of specimens. Also, they, for exclusion criteria, cannot have flaccid limb weakness, otherwise they would be a group one subject. And of course, the investigator at the site always can decide it's not in that patient's best interest to enroll and become a subject in group two. Now, subjects enrolling in group one, as I mentioned before, could be probable or possible cases of AFM, as well as definitive or confirmed cases of AFM. There's going to be an adjudication committee, a protocol adjudication committee, that will look at the cases enrolling in group one and make an ultimate determination as to whether they remain possible, probable, or confirmed AFM cases, or whether they are a non-AFM case. Now, if they're adjudicated to be a non-AFM case, they've already enrolled in group one, so they will slot into a group 1B designation. Whereas if they're continued to believe to be possible, probable, or confirmed cases, they will slot into a group 1A categorization. And this assessment's anticipated to be done somewhere between 3 and 6 months after subject enrollment. We got to get enough information into the database. We have to get the images into the database to be able to have those available to the adjudication committee. That committee is going to consist of 2 neurologists from the program or protocol committee that will be overseeing this study. If they are in harmony with respect to their conclusions, then the classifications are made. If they are discordant in their assessments, then a third neurologist comes in, and they can always pull in other expertise as well, such as neuroradiology, if and as needed. Here are the schedule of events for group 1 subjects. So these are the possible, probable, or confirmed AFM cases. And it's a busy slide, but I want you to be able to appreciate what all is going to be done in this first column, as well as the time frames that go over the first month of life, month following enrollment, and then at month 3, month 7, and month 12. So just to kind of point out a few things, neurologic exams will be done sequentially. This will be by the neurologists or their designees that are involved at each study site. The green font on this particular slide indicates studies that are not required by the protocol, but are, in the case of MRI especially, have been agreed upon because of the requirement in the inclusion criteria, or cerebrospinal fluid being obtained and EMG and nerve conduction studies being performed. Respiratory specimens are going to be collected at days 1 and 3. Blood, that can be serum, whole blood, PBMCs, plasma, will be collected on day 1, day 7, day 28, and month 7. Stool will be collected within the first week following enrollment. CSF, residual CSF, will be scavenged after no longer being needed for clinical reasons and will be sent to the repository. Any results of a clinical virologic workup or a clinical immunologic workup will be captured in the database as well as therapeutic procedures that are attempted. And any con meds as well will be done. And then finally, there will be assessments for degree of neurologic sequelae that will go out over that first 12 months of time following study enrollment. Now, I mentioned before that lumbar puncture, MRI, EMG, as well as nerve conduction studies are not required for protocol involvement. In other words, they're not study-related procedures. There's reasons for this. I'm happy to take questions at the end if you're interested. But as I've said, there will be sweeping up of any residual specimens that are being obtained, not only these specimens like spinal fluid, but blood as well from studies that are performed for clinical reasons. The group 2 schedule of events is illustrated on this particular slide. A couple of things to pull in here. The respiratory specimens, NP and OP specimens, will be obtained on study day 1, 7, 28, as well as also any kind of unscheduled visits if they get sick during that month of follow-up. Blood will be obtained at day 1 and day 28. That'll be, again, serum, whole blood, PBMCs, and plasma. Stool will be collected over the first 7 days, and then, if possible, as well, out at 28 days. And neurologic assessment will be performed on day 1. Any kind of development of interval illnesses will be captured at their final study appointment, which would be on day 28. And one other thing I want to point out, I didn't show this on the previous slide, but each of our study windows abut other study windows. These are difficult trials to do, and we understand that these families are going through a tremendous amount, and there may be simply difficulties in getting back for a particular study. So anytime during the total window of time or period of time that patients are being followed on this study, anytime they come in, they will fall within a study window so that we don't lose the opportunity to capture information and specimens at that particular moment in time. Now, another important aspect of this is that in the United States, we have reporting through the public health mechanisms of patients with acute flaccid myelitis as well. And so there can be confusion from the standpoint of the patient's family about who is representing whom, and about whether someone coming in to collect one kind of specimen then is followed on their heels by someone, from the state health department or a county health department coming in and trying to do the exact same thing, all at a time when families are under a significant stress because they're dealing with a really challenging medical condition. So there's going to be close coordination between the study team at each study site as well as the county or state health department, so that the specimens that are being obtained from the respiratory tract, blood, spinal fluid, and stool from the group 1 subjects, aliquots of those will be sent through the health departments, ultimately to the CDC for their public health kind of assessments and their virologic assessments as well. Those specimens are not going to be part of the research protocol or the biorepository, but there will be opportunities to be able to get that information into the research database if they're resulted back to the subject's clinical records, and we have some pretty sophisticated mechanisms to try to make sure that that happens. Now, each of the speakers prior have really illustrated that this is a major group effort, and I think that certainly describes what I've been talking about here for these last several minutes. The protocol committee is listed on this particular slide, and you'll recognize many of these names as speakers from today and speakers at upcoming AFM meetings as well. And I'm deeply indebted to them for the guidance they've provided as we've developed what we think is going to be a successful protocol. We already have one subject enrolled in group 1, one subject enrolled in group 2. There's at least 2 additional subjects that are patients, I should say, that are under consideration right now for enrollment, also at different study sites. With that, I'm going to ask that you go back into the panel discussion area, and there'll be a Q&A session, and that will be by going into your Sessions tab on the left-hand portion of your screen.